So GC is PD pending that time during admission. TSH also pending. Mother blood group O positive, PPG pending.
Even yesterday?
Huh?
Yesterday still pending ah?
Oh, tapi sudah keluar.
Uh-huh.
So GC PD normal now.
Okay.
TSH 5.06. BPG also O positive.
Okay, alright.
Okay. So this baby born lame, cynos, with absent cry. Then after that, resuscitation was started, PPV, and then so PPV for 15 seconds, then CPAP for 20 minutes. After that, able to win to room air.
Why the reason for PPV?
Reason for PPV is poor respiratory effort.
Apnea lah.
Apnea.
Okay. Alright. So one cycle only lah. Okay.
Then after that CPAP, and then win to room air, and then
how do they give CPAP?
5 CPAP peak 5.
They use what to give CPAP? They use what machine to give CPAP?
The PPV machine also?
No, PPV cannot give.
Okay.
The Embubat cannot give CPAP. So they use what? You all tak pergi standby, so you all tak tahu.
Belum pergi lagi.
Emang you all takkan pergi standby lah kat UM ni. They use Neopuff CPAP.
Okay.
The Neopuff, the one yang bagging tu, yang ada, it's a T-piece resuscitator.
That one I saw before.
Yeah,
the tap one.
Yes, that one is called T-piece resuscitator.
Okay.
Short term, famous name, Neopuff. Okay, alright. And then what happened after the CPAP? How long CPAP?
20 minutes.
20 minutes, okay.
After that, able to saturate, then win to room air. Yeah. Okay, so antenatal risk. Mother is para 3. And then mother had pre-eclampsia, and then on labetalol. Then after that, also got fetal growth restriction.
Okay.
So also high resistance Doppler. Then they gave IV dexamethasone 2 doses. So yeah.
So the reason for delivery is because
fetal distress, because there is preterm labor and then premature rupture, prolonged rupture of membrane actually.
So the prolonged how long?
More than 18 hours.
More than 18 hours. So started antibiotic.
So inadequate coverage.
How much?
Because
they didn't cover.
Because come then preterm labor.
So then deliver straight.
Yeah.
SVD
Tak, emergency.
Emergency is because of the EPE lah.
And also
plus fetal distress.
Fetal distress.
Fetal distress lah.
Yeah, and actually mother also got 2 previous scar.
Okay.
The first one is because of fetal distress also. Yeah.
Okay. So Abga was what was again?
7 and 9.
7 and 9. Okay.
Yeah.
Alright. And then?
And then postnatally, when admission to ward, noted the baby temperature 34.7, and then check reflow 2.2.
Check reflow at how? That temperature at how old of life? How many hours? 2 hours of life.
2 hours.
Okay.
So before transfer, actually 37.
Alright.
Then during transfer, bassinet. Then
Why do you think?
I think could be environment also.
Okay.
Because on the way out very cold and all. Yeah.
So?
But also possible because of like early onset sepsis.
Okay.
So
how do you want to, if you go standby, how do you want to prevent hypothermia in babies?
If possible, skin to skin contact with the mother.
Okay.
Then make sure drying.
Okay.
And then wrap the baby, maybe put under incubator for a while.
Yeah, but we don't really use incubator for standby. We use what? What do you call thing? Open hood warmer. It's called open hood warmer. So, how do you want to do to prevent hypothermia with the open warmer?
Open up the light.
No, not the lights. Open up the heater.
Okay, the heater.
Okay, the light don't do anything. So you pre-warm everything. The kain you want to use also, you pre-warm. You put 3 layers, everything. Or just put 1 layer then simpan another one lah. Okay, then you dry them up properly. And you change. If you need to change 2 times, 3 times pun also can. But after you change, you wrap them lah. You wrap them at least 1 or 2 layers. Then if you, more important thing, the transport lah. The transport incubator tu yang problem tu. Most of the time the transport incubator not working. cannot be preheated.
Oh.
That's why they hypothermic Okay, then this baby prank some more arteries. Okay, alright. So, okay, then what happened?
Then subsequently started feeding. And then also started on drip. D10. Then after that the glucose came up and then warmed the
So they give bolus or not?
They didn't give bolus.
They give feeding only.
And then D10 the drip.
Okay.
Two meals per hour.
2 meals per hour.
Maintenance.
2 meals only? What's your chicken?
4.2.
Oh, 4.2. Okay.
2 meals per kg.
What do you mean 2 meals per kilo? That one is bolus
Oh. But then they write there 4.2 meals per hour.
That one the drip got.
Oh, okay.
How do you calculate? What's the weight?
2.06.
2.06 Calculate how they get 4.2.
I calculate is times 2. Then it's 4.12. But because we can give 2 to 3.
No, how you calculate the drips in day 1 of life?
Day 1 of life,
Newborn.
60 times 2.06. Then divide by 24.
Should be 5.2 lah the drip. I don't know how they calculate wrong or what, not sure
Oh, they started feeding also like 10 cc per.
Okay. So, yeah, probably another 10 cc tu they minus lah.
Oh.
How?
Minus 0.95.
So if they're giving feeding 10 cc 8 hourly, then what's the balance you can minus so that you can get the drip 4.2 tu? Times 6 Times 8 lah.
Times 8.
Feeding
3 hourly.
So total fluid berapa total the whole day? Tolak 80. No. That's the whole day. You minus 80. Minus 80.
43.6.
That one haven't divide. Divide by 24. 42.6. Divide by 24. That's a drip if you want to include the feeding. I don't know how they calculate lah.
Oh, they bring it 1 day forward.
So because 90 lah. So count 90.
Let me count. 4.39. Okay.
That's how they get lah.
Yeah.
Okay, at least you show me how to you get the calculation. At least you know lah how to calculate. So if you want to give bolus that 2.2, how much you want to give? 2 meals per kilo.
2 meals per kilo. Up to 3 meals.
3 meals per kilo. Okay, so you give 4 meals. Just give bolus lah. It's not drip infusion. So whatever you think just now is wrong concept already. Okay. So the reason they get is they just advance 1 day forward lah. Okay. So was it the correct management or hypoglycemia?
Hypoglycemia.
So initial hypoglycemia management apa? The patient can feed.
Start feeding first.
Start feeding first. Then after that?
Then only
after that
we assess after 30 minutes.
Okay.
Then if still low, then only we consider bolus.
Okay. Alright. So you give bolus, lepas tu you start drip or not?
Kalau dia masih
hypo lah.
Hypo.
Okay, but this one seems like they don't want. If patient persistent hypo, you need to keep them nail by mouth.
Oh yes.
Why? Why you need to keep them MBM if patient persistently hypo? No, don't know. The reason being, from the feeding, it's very hard to calculate the percentage of glucose going in.
Okay.
There is a calculation, but I also don't really practice per se. We keep them MBM, we give glucose drips D10. However, because you can calculate the GDR, glucose delivery rate. There is a method to count from the susu, but it's very difficult. It's not convenient. Just keep them MBM. You can count the GDR. You know how to count GDR?
I remember it's something hourly rate.
Okay.
Then you divide with 6 times the body weight.
That's good, but you need to times the
The percentage of glucose.
Yes. Take glucose time divided by the delivery rate, and then the this is the okay. Alright. Then so the GDR will determine lah. If more than 6-7 is quite high already lah. Okay, so you need to kind of investigate. Is patient persistently hypo? Okay, alright. If patient persistently hypo, what do you sign?
Okay.
What do you need to sign?
Critical blood sampling.
Yeah. So what inside it?
Inside got insulin.
Okay, some more?
Other hormones like cortisol, I think.
Okay, alright. Lagi?
Ketone.
Can? Lagi?
Amino acid
No lah, not amino acid.
Okay.
You may send IEM, but this one is separate entity lah. But it's not part of critical sampling. Okay. Yes, you sign also the level, the
serum glucose.
the steroid level, everything tu lah. Okay. It's part of the critical sampling lah. But not, you don't sign everything one go lah. But most of the time, I want insulin, I want ketone, I want all those things like this. Because you want to roll out the PHHI1, persistent hypoglycemic hyperinsulinism of infancy, which is quite common in patient with mother with
GDM.
Yes. Okay. But in this child, what do you think the hypoglycemia due to?
Could be because of the sepsis.
Yeah. Okay. So what do you think patient has risk of sepsis?
The prolonged rupture of membrane.
Okay.
More than 18 hours and it's not adequately covered.
Okay. If we say is adequately covered with antibiotic, what does it mean?
Means we need at least 4 hours. So at least 2 doses.
4 hours from
dose,
first dose antibiotic until to the
second dose.
To the delivery lah.
Oh yeah.
Okay, like if deliver at 8 p.m, you give first dose at 4 p.m, that's adequate lah, even though it's single dose. Sometimes you know it's 4 hourly antibiotic, you should receive second dose already lah. But sometimes you nak prepare apa semua, you may give like 5 hours later. But actually one single dose, but at more than 4 hours, is actually cover lah. So simple term 2 doses lah. But if I'm being critical about it, I just want to know when you serve antibiotic when baby delivered. So I want to say adequately cover or not lah. Okay, because as an MO before, you were like, macam ni tak cukup cover, you want to start antibiotic or not. You have to decide lah. So sometimes I don't want to basically admit every patient. So sometimes I just being critical lah, get the antibiotic bila pagi. So but most accurately 2 doses lah. But because the antibiotic mothers most of the time is 4 hourly one, if I'm not mistaken. Okay, alright. So if patient got sepsis, newborn, usually what kind of bacteria?
Early onset sepsis is GBS.
Okay, some more?
And E. coli. Sometimes Listeria. Cons also possible.
Cons only after, not really
late onset.
Immediately.
Okay.
It's not late onset, it's probably a few days in what already? Because you poke them, you get cons lah.
From the skin?
From the skin. Cannot get from the mother one. Okay, mother remove everything from the vaginal tract lah. But this one also low risk. Yeah, low risk because she's baby not delivered vaginally. But because PRM, there is ascending infection. Okay, so even that also pose a risk to the baby lah. Okay, so GBS and E. coli. So what antibiotic you start normally?
Benzoyl-penicillin and also gentamicin.
So benzyl cover what?
So benzoyl-penicillin covers the gram-positive group, so that would cover the GBS.
Okay.
And then gentamicin gram-negative, so cover E. coli.
Okay. So you said Listeria. So if Listeria, what are the features usually suggestive to say this one is Listeria? Simply semua dia. What is it?
Breastfeeding?
No? Who are at risk usually?
Okay, this I'm not sure.
No. If Listeria, usually prematures, the tongue will greenish green stain, meconium stain kind of thing. But basically it's not meconium. It's more of like the liquor is green because of listeriosis.
Oh, okay.
So that's why sometimes pram baby got meconium stain, they suspect listeria, but because meconium also green, so very difficult to differentiate those two. Understand? So sometimes every meconium stain they cover lah, but actually the listeria itself causing the liquor to turn green. Okay, but you must have that history. They taking what food mother takes during the second trimester.
Seafood.
Not seafood lor. Listeria in what? In what food? It's okay if you don't know. In the cheese. It's a unprocessed kind of cheese, the pure cheese. We had a listeria, pure listeria proven during my master time. I was 2017 something. Memang typical history, mother took some cheese, greenish, liquor, whatnot. Yeah, culture grew listeria. Yeah, those are typical symptoms lah. Okay, alright. So if patient have GBS, so where does the infection can localize to?
To the lungs.
To the lung, so GBS pneumonia. So other than the lung, where else they can go?
They can go to the gut.
Yes. Not really.
Meningitis.
Yes, meningitis lah. Actually, lung, meningitis and the bloods lah. So it's the lung, the bloods, the brain. Okay. So GBS pneumonia is probably one of the common complication of GBS infection. Sometimes it doesn't involve pneumonia, it's just the bloods and also the brains lah. But if patient GBS pneumonia, they can be quite bad. What kind of level of bad we talking about? PPHN level bad. Persistent pulmonary hypertension newborn, very bad. Need multiple inotrope, cyano or whatnot lah. These are typical GBS punya sepsis. Okay, so that's why be very afraid. Be extra vigilant. It's okay to overtreat meat for few days to cover properly, because they can come back late onset also lah. Because GBS also can have late onset sepsis up to 3 to 4, up sometimes even 4 months. I seen 4 months lah, but that one meningitis one at 4 months old. Okay, alright. E. coli, granite can turn very bad, very fast also lah. Okay, for granite sepsis macam tu lah. But here newborn GBS. Okay, so if you see a newborn, mother has, let's say, maternal choreo, features of maternal choreo are not really proven, like fever, intrapartum. So you cover antibiotic or not cover antibiotic?
Cover.
Macam cover lah, especially patient to premature ke apa lah. But if you follow the sepsis guideline of newborn tu, it's always the term 38 week and above pram. So 38 week usually a bit more robust, so the criteria is be very specific before we start antibiotic. Sometimes when you are the one making decision, you don't want anything to happen, you decide to overtreat, you just cover sajalah, simpan centang. But even that, we still cannot save every babies lah, because not every babies are screened to have GBS one. Not every mothers have a high vaginal swab to say lah. Okay, but those are the PROM, basically one of the telltale sign lah to basically patient have GBS lah. Okay, PROM. Okay, so kalau patient the antibiotic IVC pen for sepsis and compared to IVC pen for meningitis, what are the difference in terms of the dosing?
Meningitis needs higher dose.
So the sepsis dose is what?
Sepsis dose is 100,000 units
per kilo.
per
How frequent?
dose. BD.
Then meningitis?
Is it double?
Double what?
200.
No, It's not double, same only.
Same only.
But
TDS.
no.
QID.
Yes.
Oh.
QID. Yalah. Some may give higher doses with QID as well. Don't remember. Maybe some places 150 or 200. I can't remember. Depends on their own pharmacy books, guideline, whatever. But in general, it's QID lah. Double of this, everything. Okay. So if you suspect GBS meningitis already, antibiotic you want to change to what? Now patient on Cipengenta. Then what antibiotic you want to change to?
Suspect meningitis.
Yeah, GBS meningitis. Okay lah. But
increase the frequency.
Okay, you increase the frequency to QID. But what about the Genta? Does it cover? Does it go to the brain?
No.
No, so you need something higher.
Is it Venco?
No, not Venco. Venco for MR cons, yes lah. Or MRSA, yes lah. Okay, if GBS, most of the time it just depends. Okay, but when you suspect meningitis in newborn, every baby's less than 3 months, we always start these two combo lah. Cipen and something. What something is that? When
something that can cross the blood barrier.
Usually, one is already penicillin, the other group is what? Cephalosporin group. What antibiotic?
Ceftriaxone.
But we don't give ceftriaxone in unit. We can give lah, but we don't practice properly. Because there are reasons for it. So, other than ceftriaxone, what else? The third generation. Cefepime 4th generation already. Don't know?
Don't know.
You only know ceftriaxone. K4 what? K4? No, that one cephalosporin. That one different medication already. Cefotaxime.
Cefotaxime. Okay.
So sometimes patient on Genta got some AKI, we off the Genta, change to cefotaxime. That's probably another reason lah they get on cefotaxime. But suspect meningitis, newborn, Cipen cefotax lah. Okay. More than 3 months, yes, you can give ceftriaxone lah. Do you know the reason why we don't give ceftriaxone in newborn? No. Will displace your bilirubin from albumin. Conjugated bilirubin can bound to albumin. So ceftriaxone want to bind to the albumin as well. So displace bilirubin boleh naik lah. So kalau day 1, day 2, day 3, first 1 week, 2 weeks, so sangat-sangat tak sesuai lah. But if not jaundice anymore, it's okay to use ceftriaxone. Okay? But not in probably 2 months, 2 weeks of life and less lah. Okay? Alright. Okay lah, cukup.
Okay.
You want emergency question lah?
Doctor, actually got no paper to sign.
You logbook?
So,
nanti I tell Dr. Hana lah.
Okay. Okay, I ask for your help to sign my leave.
When?
Yang ni untuk 20 hari bulan Disember.
I'm not APA specialist.
Anymore?
Yeah, I'm a 5PB already.
Oh, I see.
You tell Dr. Hana lah. Okay.
Thank you.
Okay.
Doctor, I got a question. Actually, when do we cover 48 and when do we
48? Cover what?
Yeah, the benzylpenicillin and gentamicin. How do we know 48 we can off and then 5 days? So kalau dia maternal choreo, we straight away 5 days?
Yeah, it's always sometimes it depends on why you want to cover the antibiotic lah. Presumed sepsis, yes, you may 48-72 hours culture no growth at least 48 hours, then you off antibiotic and let them go home lah. But if patient clinically not presumed sepsis, clinical sepsis like your baby, hypoglycemic, got risk of sepsis, then you probably want to give at least 5 days. You want to know culture so grows anything or not lah. Then you want to cover properly. Okay. In presumed sepsis, mother have fever, whereby you not sure this infection affect babies or not. Okay, sometimes it affect, sometimes it don't affect. Okay, if not affecting baby is well, baby feeding well, no hypoglycemia, no tachypnea, no sign of meningitis or anything, then after 48 hours, you review the bloods, no thrombocytopenia, white cell okay, no low white cell, no high white cell, nothing suggestive for infection, then there's probably few signs already lah. You may want to shorten the antibiotic. You probably just cover to be on the safe side. Okay, but if patient maternal choreo confirm chorioamnionitis, not just fever, because of sometimes they have fever, they got flu or something, they fever also lah. Okay, like so called this intrapretum sepsis. But if maternal, so the history of the mother very important lah. Maternal choreo, foul smelling like high grade fever, those kind of thing I don't really worry about. Those ni lah, just straight away cover 5 days, because those sepsis are very very high lah. Okay, those yang not sure sometimes borderline, then you may want to shorten antibiotic lah. Okay, then patient come maybe got fever at home, but in the end up being overlapping. So you cover also lah 1-2 days, then okay, then let them go back. So that's another possibilities lah. Ultimately, the decision is always based on the histories. Then you can decide lah. That's why history, antepartum, antenatal, all very important lah. Okay, so if patient, another example, your GBS, but you cover because of this one lah, history of mother GBS, then maybe inadequately cover, but baby is clinically well. So you want to probably shorten antibiotic also. If ABC okay, baby okay, culture negative, you can start antibiotic lah. Baby no signs of sepsis. Sometimes you start antibiotic, you just prophylactically cover rather than you treating that. Okay. Alright. Okay.
Thank you, Doctor.